Hi, my name is Julie Leviter. I'm at Yale University. We're going to be talking today about point-of-care ultrasound for small bowel obstruction. Our goals for this talk are to discuss the indications, probe selection, image acquisition, normal anatomy followed by pathology and abnormal findings, and the test accuracy of point-of-care ultrasound for small bowel obstruction. We'll end with an illustrative case. You should use point-of-care ultrasound anytime you have clinical suspicion for a small bowel obstruction. This includes patients with undifferentiated abdominal pain, nausea, vomiting, failure to pass stool or gas, abdominal distension, or any risk factors for SBO, including prior surgeries, malignancy, and prior small bowel obstructions. Why use point-of-care ultrasound for small bowel obstruction? Abdominal radiography has traditionally been the first-line imaging, but it has a low sensitivity and a low specificity. The standard is computed tomography, or CT, but that involves radiation exposure. Point-of-care ultrasound gives you an expedited time to diagnosis, no radiation exposure, and a high accuracy. So which transducer should we use? For adults or patients with a larger habitus, we would use the curvilinear transducer to give us deeper penetration. However, in children or those with a small habitus, we can use the linear transducer to get better resolution of the superficial loops of bowel and the free fluid in between those loops of bowel. So how do we actually perform this scan? We'll start with our patient in the supine position, and we'll scan the loops of bowel in a systematic inverted U shape, followed by the quote-unquote lawnmower technique, all the while using gentle but adequate graded compression to displace the bowel gas. So let's take a moment to talk about the normal anatomy that we'll see. At the top of the screen, superficially, you'll see a single hypoechoic muscular layer about 2 to 3 millimeters in thickness. Below that, you'll see peristalsing bowel contents. Bowel contents are usually heterogeneous with stool of various echogenicities mixed with bright hyperechoic gas bubbles. You'll see popping into view these large areas of hyperechoic bowel gas within the lumen with dirty shadowing posteriorly, which obscures the deeper structures. What abnormal findings will indicate to us that there could be a small bowel obstruction? Well, we'll see dilated loops of bowel greater than or equal to 2.5 centimeters, and we'll see bowel wall thickness of greater than or equal to 3 millimeters. We'll also see free fluid, alternating peristalsis, and akinetic loops. We'll look at some examples in the next few slides. Let's talk about some abnormal findings that we may see. One is dilated loops of bowel, as you see here, as well as this free fluid in a triangle shape as it infiltrates in between the loops of bowel in what is nicknamed the quote-unquote Tenga sign. Here we have an example of akinetic loops of bowel that are not peristalsing, and we see some to and fro motion of bowel contents. Let's talk about the test characteristics for small bowel obstruction. According to a systematic review by Pourmond et al., the presence of dilated bowel over 25 millimeters or 2.5 centimeters has the highest specificity among other criteria in diagnosing SBO. Decreased bowel peristalsis has the highest sensitivity among other variables, but low specificity. The presence of intraperitoneal fluid has the lowest sensitivity of all, of 4.5%, but a high specificity. POCUS to diagnose SBO overall has a sensitivity of 92% and a specificity of about 97%. This makes it comparable to the accuracy of a CT scan. This brings us to our illustrative case. A 4-year-old boy presents to the emergency department with a history of 20 episodes of non-bilious, non-bloody emesis over the past 24 hours. He has had no passage of stool for the duration of his symptoms. He has a history of an open appendectomy for perforated appendicitis 2 years ago. His physical exam reveals these vital signs: a temperature of 37.5 Celsius, heart rate of 140, a respiratory rate of 30, blood pressure 90/50, oxygen saturation 97%. He's tired appearing and looks moderately dehydrated. He has a mildly distended abdomen, is diffusely tender, does not have guarding. Point of care ultrasound is performed, and this is what you see: dilated loops of bowel, absence of peristalsis, to and fro motion of bowel contents, and thickened bowel walls. This patient was immediately diagnosed with a small bowel obstruction prior to CAT scan or X-ray. A nasogastric tube was inserted which drained bilious content, and the patient received intravenous fluids. Abdominal radiography reported distended small bowel loops with multiple air fluid levels. The patient failed a trial of conservative management and ultimately required lysis of his adhesions in the operating room. He ultimately recovered without complications. Our key take-home points for POCUS for SBO is that it is highly accurate and it has comparable test characteristics to CAT scan without the radiation. It also gives us an expedited time to diagnosis. Our key findings are dilated loops of bowel greater than or equal to 2.5 centimeters, a bowel wall thickness of greater than or equal to 3 millimeters, free fluid, alternating peristalsis, and akinetic loops.